Yes, it's on.
Okay, so you can continue.
Thank you, Chief Chief Kweke. Chief Okopi, please, can you help us tonight? Asking for too much. But I know you can help us.
Oh, you want me to share?
Yes, please. And I don't know if you can also record.
I have a laptop, even from Genesis to Revelation.
I've started the
I've never
recording.
recorded.
I've started the recording.
Do not press it again.
Okay,
The
thank you, Chief.
recording is ongoing now. For quick is
Yeah.
record.
Yeah.
Can you kindly help us here, Chief Okopi?
Let's share the document now. Let me see if I can get to. But is there any among the persons going for this exam? Is there anybody that can share, please? Let's have the persons to share so that it will be fluent with you guys. Because in between, I'll be working on. I'm doing a research on something, so I'm working on my system too.
Okay. Sorry about that. Using my phone, I'm on call. That's why I
Can
can't
somebody
share.
share? Okay, let's get Dr. Uvunda to help us share this slide. Dr. Florence, Kalamama, Flo,
Hello, Chief.
please
Good
can you help
evening.
us? Yes, good evening, ma'am. Can you help us share the document?
I'm not really a computer guru like that. So
Can you imagine? Wow, I didn't know that. Fine people. I thought all fine people
now let Dr. Buda is very good at that. He's our ICT person, so I think you should share. You'll be better
Okay,
at that. Thank you so much.
Dr. Uvunda, please can you help us, sir? Thank you, sir. Let us, Dr. Uvunda, sir, please help us. Oh, Dr. Precious and Ajero, thank you so much. So,
Thank you,
Dr.
Precious.
Adeyanju, over to you. Thank you.
Thank you, Chief, for the guidance. Thank you so much, Dr. Precious. Like I said earlier, Dr. Cyril is not unavailable for now. I'm supposed to take question 21 to 30, but we will skip that for now and come back. We'll be starting with Dr. Ayodeji. We'll be taking 31 to 40. So please kindly help us move the question to 31 to 40, Ma. Thank you so much. Dr. Ayodeji, please, are you online?
Yeah. Good evening, senior colleague. Sorry, my voice is a bit low. I'm under cold, but I will try to be louder.
We can hear you loud and clear, sir. Sorry
Okay.
about it. Yeah.
So I'm starting with 31. Which of the following statements regarding ST segment changes during exercise testing is true? A. The electrocardiographic localization of ST segment depression predates the anatomic territory of the coronary obstructive disease. That's false. It's the ST segment elevation that does that. The depression doesn't. So it could predict ischemia, but not the anatomic territory of the. So this is false. Hello? Hello? Hello?
Hello,
Can you hear
hot.
me?
Yes, we can hear you.
Okay. So A is false. And the J point is the proper isoelectric reference point on the ECG. Well, the proper reference point is the TP segment. TP segment is the proper and not the J point. So this is also false. The J point depression during exercise is diagnostic for significant cardiac ischemia. It is said that J point depression during exercise is said to be a normal finding. So this will be false too. The persistence of ST segment depression for 60 to 80 milliseconds after J point is necessary to interpret the electrographic response as abnormal. This is true. And the E option, the ST segment depression must be present both during exercise and in recovery to be interpreted as abnormal. This is not true. It is said that the ST segment can either be present during exercise or in recovery phase. And it's said in about 10% individual, you only have that ST depression occurring just only in the recovery phase. So this option E2 will be false. So the correct option here is D. That's 31. Hello?
Hello, we can hear you.
So contribution or addition? Any question?
Please, let's ask our questions and make contributions. Well, maybe we'll move to the next question. Nobody is asking any question.
Okay. Question 32. An ECG is obtained as part of the routine perioperative evaluation of an asymptomatic 45-year-old scheduled to undergo wrist surgery. The tracing is shown in figure 1.6 and is consistent with A, right ventricular hypertrophy, B, left posterior vascular block, then C, reversal of limb lead replacement, D, left anterior vascular block and counterclockwise rotation, E, dextrocardia with situs inversus. Well, the figure 1.6 is showing, of course, the lead one is negative. And if you look at the AVRL, there's positivity in AVRL, which is unlike what you should have in a normal finding. So there's a negativity in the lead one, positive in AVRL, and then, so the option is, they said A is RVH. Well, looking at this lead, there's no RVH here. And then option B, left posterior vascular block, which is unlikely, though there's a right axis deviation. Looking at this, however, to make the diagnosis of the posterior vascular block, you have a prominent R wave in 1 and AVL, which is not what we have there, even though there's right axis deviation greater than net. And then C, reversal of limb lead placement. The reversal of limb lead placement, lead one will be negative, and the AVL will be positive. All the leads, I mean, there's negativity. There's negativity in AVL. And when you look at the R wave progression too, there is normal in lead reversal. There's normal R wave progression, which is also normal here. There's the R wave progression from V1 to V6 is normal here. So maybe I'll just start this one. Then D, left anterior vascular block. Left anterior vascular block, you have extreme left axis deviation between -45 to 90. And then you have prominent Q wave in 1 and AVF, and the S wave in inferior leads, which is not what we have here. So that is out of it. In dextrocardia, of course, in dextrocardia, you could have In addition, you can have negativity in the 1 and AVF. However, there is absent airway progression in the chest lead. That is, other than having airway progression, what you have is you have prominent S wave, dominant S wave, not the chest leads. So, which is not what we have here. Here, there's negativity of the AVR. Lead 1 is negative. And if you look at the airway progression too, seems to be normal. So I think it's C, lead reversal seems to be the correct answer. Hello? Hello?
Yeah, audible, sir.
So questions, clarification. Hello?
Hello, good evening.
Yeah, good evening.
Yes, thank you, Dr. Olade.
Yeah.
Maybe just some little clarification. If you look at them, lead 1 and lead 2, then lead 3 AVF. So the lead 1 is actually a negative deflection. Lead 2 is equally a negative deflection.
Yeah.
So the axis here is actually a northwest axis, an indeterminate axis, as against the right axis deviation. I think this should be an indeterminate axis.
Okay. Sorry.
Yes, because of that lead 2 that is down. Yes. Then another catch to it is that for if you're thinking dextrocardia should be reversal of the KRS progression from V1 to V6, which we don't have here. So I think that's another, yes. So if it's dextrocardia, you would see it keeps being negative down to V6. We know it's dextrocardia. Then for that helps us to rule that out. So this is not even a right axis. So left posterior vestibular block is out of the question. Right ventricular hypertrophy is out of it. That one is easier. So it leaves us to limb reversal, which if you now look at lead 1, you see that the P wave is negative in lead 1. So it just shows that there's a problem with the leads, the limb leads in this ECG. Thank you.
Yeah.
Thank you, Dr. Molari. Dr. Ayodeji, you can continue, please.
Okay. Yeah, 33. Which of the following statement is correct regarding exercise test protocol? A, regardless of the exercise test protocol, the heart rate, systolic and diastolic blood pressure all must increase substantially to achieve a valid test. This is false. Depending on which test protocol you're doing, there are some that you have a decrease, even in systolic blood pressure, and that suggests a form of a severe arterial disease or multi-vessel disease. So you don't have, so this is false. A bicycle, treadmill, and arm ergometry protocols all produce approximately equal heart rate and the blood pressure responses. I think this is also false. The heart rate in the bicycle treadmill is said to be, in the ergometer is said to be more. It's said to be more compared with the bicycle and the treadmill. However, the the oxygen consumption said to be less compared to, as in the workload, compared to the bicycle and treadmill. So option B will also be false. The standard boost protocol is characterized by only small increases in oxygen consumption between stages. That's false. There's also not increase, there's a large increase consumption even between the stages, not small. There's a large oxygen consumption between the 7 stages that we have in the boost. So I think this is also false. A fall in systolic blood pressure during exercise is associated with severe coronary artery disease. This is true. An optimal graded treadmill exercise test rarely requires more than 5 minutes of exercise on the Bruce protocol. This is false. I think it requires more than 5 minutes of exercise, which hello.
I think you should continue if there are no contributions.
So I think the option D is the true one for 33.
Yes.
So 34. Which of the following patients is least likely to have a cardiac cause of his or recent onset of dyspnea? An active 54-year-old man with a congenital bicuspid aortic valve who has recently noticed shortness of breath walking the usual 18 holes of golf. It can occur with this, so this will be false. This patient has may have a congenital aortic stenosis, and you know the onset of symptoms usually in the 5th and 6th decade of life. So it's not, they can have dyspnea at this stage. So this is false because in bicuspid aortic, the onset of usually in the 5th and 6th decade of life. So this is false. Then be a 70-year-old woman who sustained an anterior myocardial infarction 1 year ago with a left ejection fraction of 50 at that time. She has not had recurrent angina, but has noted dyspnea during usual housework over the past 2 months. Well, this too can also be false because possibility of the left ventricular remodeling following an MI, patient could become symptomatic. So this is also false. A 46-year-old woman with history of asymptomatic rheumatic stenosis who recently noticed irregularly palpitation and shortness of breath while climbing this. Well, this patient initially asymptomatic rheumatic MS, of course, with arrhythmia, most likely the atrial fibrillation, they tend to become symptomatic because there's decrease in the diastolic filling time, and patient at that time, patient could present with symptoms. So C is also false. So they can present, so it makes it false. And D, a 38-year-old woman with a previously symptomatic ostium secundum ASD, now 8 months pregnant, asymptomatic ostium secundum ASD, now 8 months pregnant, who has noted shortness of breath during her usual weekly low impact aerobic class. So for this, This is likely to have because for the pregnancy to have been carried to 8 months. So the most likely cause of the breathlessness usually must be because of the abdominal distension. There will be like splitting of the diaphragm. So it's the likely cause because of the increased abdominal, the gravid uterus. So the diaphragm can become split, and this cause the difficulty of breathing. So I think D is true here. And the 22-year-old with trisomy 21, and he has more what describes shortness of breath, carrying grocery bundles over the past 3 months. Well, these two can also have, they commonly have endocardial occlusion too. And they could also have a cleft mitral regurgitation too. So this patient too can also present with a cardiac cause. So the most likely, the true answer is D. 34. Any question? Hello?
Hello, Dr. Ayodeji, we can hear you.
Okay. Questions, clarification, or any addition? Or I should just continue?
There is none for now. Let's just continue.
Okay. A 79-year-old woman with history of hypertension and dyslipidemia is referred to a cardiologist because of a recent exertional dyspnea and a systolic murmur. Examination is notable for a heart rate of 91 beats per minute, blood pressure of 170/68 millimeter of mercury, the JVP 12 cm of water, and a grade 3/6 late peaking crescendo, the crescendo systolic murmur at the upper right sternal border with diminished intensity of the second ascent. There is trace bilateral ankle edema. A transthoracic echo revealed mild left ventricular hypertrophy, normal biventricular systolic function, a transaortic peak velocity of 3.5 milliseconds, and a mid gradient of 29 millimeters of mercury. A calculated aortic valve area of 0.8 cm using the continuity equation. The dimensional index is 0.3, and the left ventricular stroke volume index is 47 mil per meter square. He undergoes cardiac CT imaging that reveals aortic calcium score of 2,531 Aston units. Excuse me. What is the most appropriate recommendation? Well, if you look at the presentation and even the examination of this patient, is pointing to a patient with aortic stenosis because of the late peaking crescendo, the crescendo systolic murmur at the left upper sternum, and is likely to be a severe AS. Looking at the aortic valve area, the normal area is between 3 to 4. So anything less than 1 cm square makes it a severe. And even with this character of murmur too, they said the late crescendo systolic murmur at the left upper sternum with diminished intensity. So there is increased severity of the AS with diminished intensity of the second ascent. And over time, they said the even it can even disappear. So the options are A, echocardiography reevaluation. So this is a severe aortic stenosis, symptomatic aortic stenosis. And looking at the gradients, like a moderate gradient. And then A, echocardiography evaluation in 6 to 12 months is the appropriate, that's false. Patient is already symptomatic, has severe AS. Referral for aortic valve replacement is likely true. Double timing stress echo. Well, this is, you wouldn't want to, is a class 3 indication because patient is already having a severe aortic stenosis, symptomatic stenosis. So it's a contradiction to even a stress, double timing stress test. You only consider this maybe asymptomatic, low flow and low gradient aortic stenosis. Exercise stress echo, this is also false. So the true answer here is the B, referral for aortic valve replacement. That's the true answer here. Hello, are there questions, clarifications, and addition? Hello? Hello?
Hello, Dr. Ayodeji. I guess I've understood what you've said. The class is pretty quiet tonight. Please, let's make clarifications. Dr. Adedeji Adebayo.
Okay. Hello?
Hello, Dr. Ayodeji.
I thought somebody wanted to make comments.
I thought so too. Dr. Adedeji. Good evening. We thought you wanted to make more comments or clarifications.
No, ma, I was.
Okay. Thank you. Dr. Ayodeji, please continue.
Okay.
Sorry, good evening.
Yeah.
Good evening.
Good evening. Yeah.
Yeah, sorry, I don't know when, I was just thinking that discussing a question like this, maybe we can just also do well by just reminding ourselves some indications for valve replacement in aortic disease, maybe like this kind of case, just to maybe be an additional point to the question. So that it won't just be that the question is just what we are focusing on, can also be using it to also remind ourselves some things. Thank you.
Okay. Well, the class 1 indications for patient for AVR, the patient has symptomatic patient with severe AS. Severe AS with reference to the AVA, the aortic valve area less than 1. And you also talk about yes, or patients severe AS undergoing CABG surgery, or patients going for maybe either aortic or other heart valve replacement. You also want to do patient going for other valve replacement, and patient has severe AS. You also want to do an AVR for them too. And also patient with severe aortic stenosis with left ventricular dysfunction less than 50%. Also an indication for valvular replacement too. These are like class 1 indications.
Yes, thank you very much, sir. We can proceed.
Okay.
Thank you very much.
Okay. Question 36. which of the following statement regarding nuclear imaging and acute myocardial infarction is true? A, the size of resting myocardial perfusion defect after an acute AMI does not correlate with patient prognosis. Well, this is false. It does. The larger the resting myocardial perfusion defect, the worse the prognosis. So this is false. An increased long uptake of radioisotope at rest correlates with an unfavorable prognosis. Well, this is true. Well, with the increased long uptake, it means makes the prognosis unfavorable, and the risks of reperfusion or revascularization. I mean, after it came in, I mean, with the risks of improvement, even with revascularization, said to be not beneficial. Even patient who has had with increased lung uptake, because they carries favorable prognosis. The submaximal exercise imaging soon after MI is a better predictor of late complications than adenosine myocardial perfusion. This is false. The adenosine, that is using a vasodilator, being a vasodilator, said to be a better predictor of the late complications compared with submaximal exercise. So that would be false. The tactician 99 STBB imaging is inaccurate in assessing the effectiveness of reperfusion. On the contrary, it is very effective and accurate in assessing the effectiveness of reperfusion therapy. So the correct answer here is B. That is the increased long uptake of radioisotope the mechanism of the thing, I don't see, but I know Prof also taught us about this, but I can't remember the longer the increase the uptake of the long uptake. I think the more, but I can't the mechanism behind it. But B is the true answer.
I myself, I was a little bit confused with the question. Chief Kweki, please, can you help us out? I'm not sure Prof is online.
All right, which question is that?
The
Oh my.
regarding nuclear imaging and acute 36.
Why?
36.
Yes. Yes.
Which number?
That's why.
36.
Yeah,
Oh.
which of the questions? All the questions or
The
which of the
options there,
options?
yes. The options there.
Can you zoom in a little? Which of the following statement regarding nuclear imaging and acute myocardial infarction is true? Yes. The size of the resting myocardial perfusion detect after acute does not correlate with patient prognosis. So they are looking at nuclear imaging. Can you just come down? In MI. So the size of the resting myocardial perfusion defect after acute MI does not correlate to the patient prognosis. So that's a false, right? That's straightforward. Nuclear imaging, basically, that's what Prof was trying to talk about yesterday. That basically the SPET and the PET. And Prof talked about the differences yesterday in terms of artifacts and duration of radio tracer. Okay, so yesterday we also talk about those guys that are in the intermediate risk. So when we talk about using a test to be able to rule in or rule out, so you make use of these nuclear images, the PET, and the SPECT. Other things you want to use are things like cardiac MRI, or commonly you can make use of CTPA. No, not CTPA. CTPA, I mean to say, you can make use of CT coronary angiogram, not CTPA. Then in places where you don't, you can make use of stress ECG, stress echo, as the case may be. But here, you're talking about nuclear imaging, which is typically the PET and the SPECT. So, say the size of the resting myocardial perfusion detect. So, correlate to prognosis. So that's false. B may increase long uptake of radioisotope at rest correlates with an unfavorable prognosis. Sorry, my children are really disturbing. Let me just take care of. Hello?
She can eat Goldie more.
Can you hear me?
Yeah, Chief, we can.
Hope they're not distracting. A lot of noise on the background from my end.
We are enjoying their noises. So yeah, let's continue.
Okay. So increased long uptake of radioisotope at rest correlates with an unfavorable prognosis. Then let me go to the CFM. So maximal exercise image such after MI is a better predictor of late complication than adenosine myocardial perfusion imaging. So they're comparing exercise based imaging with that of adenosine myocardial perfusion. That's SPECT. So let's check if I'm not sure of that. Technician 99 system, maybe image is inaccurate in assessing the effectiveness of the perfusion therapy. That is also false because we will make use of technician 99 in SPECT. Okay, so you can't say it's inaccurate. So we'll be able to remove A and B. They're looking at B and C. Let me go back to that again. Increased long uptake of radioisotope at rest correlate with an unfavorable prognosis. Usually, when you make use of radio tracer, okay, you are trying to look at how the myocardium take up some of those tracers. So, for instance, in patients that are using PET scan for, you tend to make use of the FDG, that's radio tracer glucose. Okay, so increased long uptake of radio tracer at rest correlate with an unfavorable prognosis. I don't think so. So I would, this submaximal SI imaging, such as after MI, is a better predictor of late complication than adenosine myocardial perfusion imaging. So I would think that E is a correct option because poor exercise is an indication of poor cardiac function. So maximal exercise imaging soon after myocardial infarction. So either B or C, we can just check and be sure of where we are. Okay.
Thank you, Chief. I just checked. They are saying option D. Yeah.
Is inaccurate in
B.
assessing.
Option B.
Yes.
Option D, they said.
B.
B.
B
I'm
for
surprised.
ball.
Okay, so that's yeah.
Or maybe we can just project and go and look at the answer.
Option B or C.
B for
yes,
ball.
B is fine. It's fine. Yeah, that's okay. Either B or C. Either B or C.
Okay, thank you so much, Chief.
That's fine. Yeah.
I don't know. Should we go to the answer and read it out?
You
I
can read
think
it
so.
out, but I know that if you keep, you can read it, but if you keep reading all questions, you won't catch up. This is barely have 2 months. You have 700 questions.
Yes, yes.
You understand? So, and some of these parts are not very, very important, even though you need to know it. So I don't know. It's up to you guys.
Yes,
If
I think
there's time to read through, you can. It's just up to you. But you have a lot, a more important area of cardiology to really focus on.
yes. Please kindly permit us to read this one, sir.
Sorry, just a little bit. From the 10th edition, the answer is C, while the 12th edition, the answer is B. So I don't know which we are going to pick. Is it the 12th edition?
Wow. Sorry, can you come over that, Dr. Briggs?
Yeah, I said from the 10th edition, the answer is C. But there isn't a 12th edition, so maybe we use the latest edition.
I think we should just read it to see what they are trying to say.
Yes.
Mm.
Please, Dr. Precious, you need to zoom in so that I can say it and read it out. Okay. Okay, don't worry. Myocardial perfusion imaging with either thallium-20 or technetium-99 labeled compound is used for the detection of myocardial ischemia and infarction. To characterize infarct size, which predict future ventricular remodeling, and to determine the effectiveness of acute revascularization. Sorry, let me see if I got that right. Okay, thank you. Keeps going back and forth. Okay, I'll read that again. Myocardial perfusion imaging with either thallium-201 or technetium-99M labeled compound. Dr. Precious.
Apologies, please. I'm zooming in and zooming out, but I think it's lagging.
Okay, thank you so much. We'll wait for you.
Is this fine?
Yes, just leave it like this. I'll talk.
All right, that's fine.
Thank you so much. Myocardial perfusion imaging with either thallium-201 or technetium-99M labeled compound is useful for the detection of myocardial ischemia and infarction, to characterize infarct size, and to determine the effectiveness of acute revascularization. Nuclear imaging is also useful for early risk stratification after an acute MI. The size of the resting myocardial perfusion defect correlates with prognosis. The larger the defect, the worse the outcome, which is actually reasonable. Certain resting image patterns seen after acute MI, such as increased lung uptake of radioisotope, have been associated with an unfavorable prognosis because they are indicative of impaired left ventricular function. Pharmacologic stress testing with nuclear imaging after an acute MI has been shown to be safe and to predict in-hospital and late cardiac complication better than submaximal exercise stress imaging. Gated single photon emission compound tomographic myocardial perfusion imaging allows for determination of LV function, which adds additional prognostic information in the management of the post-infarction patients. So looking at their explanation, maybe I think that's why the reason why they went for the option B. I don't know whether there are any other comments or clarification. Dr. Ayodeji.
Yeah. Yeah, I'm here.
Okay. As I said, I think that's why they went for option B.
Okay.
Yes.
Okay.
But I don't know whether there are additional comments from the platform.
I think B is the answer. I just think maybe it's a typo, a typographic error, because from what you read, I think B is the answer from what you read.
Yes. Thank you so much, Dr. Briggs. So I guess we can move on to the next question. Thank you.
Yeah. Yeah. Thank you. 37. Okay. This is 1-year-old man presents for a treadmill exercise because of intermittent chest pain. He believes he had a small heart attack in the past. He has a history of prior tobacco use. His father died of a myocardial infarction at the age of 68. His baseline ECG shows normal sinus rhythm with Q waves in the inferior lead. At 6 minutes into the Bruce protocol, it develops mild anterior chest heaviness, and the ECG demonstrates ST elevation in lead 1 AVF 5 and 6, that is lateral leads. Each of the following statements regarding ST elevation during exercise is correct. ST segment elevation during exercise is a common finding in patients with coronary artery disease, where it will occur in during exercise, were said to be uncommon, will occur in about 1% individual, and is said to be due to vasospasm or transmural ischemia. So it's not a common finding. SC segment elevation in lead that contains a pathological Q wave at baseline indicates a severe myocardial ischemia, where it could not, it doesn't suggest a myocardial, rather, it just suggests a myocardial, it's called myocardium, that is a prior myocardial ischemia, maybe an old ischemia. So this is also false. The ECG leads that manifest the SC elevation during exercise localize the anatomic regions of the ischemia. That's true. Said the SC elevation can be used for territorial anatomic territory of the ischemia. That's true. SC segment elevation that develops during exercise is usually a manifestation of benign early repolarization. That's false. This is false. And E, SC segment elevation during exercise is said to be commonly associated with development of complete heart block. Well, this is also false. I think there's no correlation between the SC segment elevation and development of complete heart block during exercise. So the correct answer is the C, that is the electrographic leads that manifest the ST elevation during exercise localize the anatomic regions of ischemia. That's 37.
Yes, I agree with you. I think this is clear. Please, let's continue. If there are no clarification or comments.
Thirty-eight.
Excuse me, please. I have a bit of a question. May I proceed?
Yes, sir.
Hello, am I audible?
Yes, sir.
Yes, please go ahead.
Okay, great. Thank you so much for the effort. I was looking at this 37A that says ST segment elevation during exercise testing is a common finding in patients with coronary artery disease. Oh, sorry, I made a mistake. It's clear, fine. Sorry, let's proceed.
Thank
Okay,
you,
sir.
Chief.
Thank you, Chief. So 38. Which of the following statements regarding coronary calcium assessment by electron beam tomography is true? Well, I think I only attempt this, but I will also need clarification on all these nuclear imaging stuff. A, the amount of calcium on electron beam tomography correlates with the severity of coronary artery disease. Where it is said that the amount of calcium on EBT is an independent marker of severity of the CAD as detected by the EBT. So this is false. Does not correlate. Patients who benefit most from screening with EBT are those at high risk for coronary events based on traditional risk factor. This is false. Of course, the patient with high risk, you wouldn't want to do an EBT. This is a risk stratification. So you rather do a patient with moderate risk, mild to moderate risk factor, and not patient with high risk because of the untoward fatal event that could occur with high risk patient. So I think B is false too. The absence of coronary calcium completely excludes the presence of severe obstructive coronary artery disease. This is also false. Well, it is said that a coronary calcium score has a negative predictive value. However, a absent calcium score does not exclude the diagnosis of a severe coronary artery disease, from what I read. So this is also false. It has a negative predictive value. However, a negative calcium score does not completely exclude the presence of severe obstructive coronary artery disease. So this is also false. The interpretation of the calcium score is independent of the age and the gender. I think it's reference to gender. The different reference value for the male and female. So this is also false. The coronary calcium score higher than the median confers an increased risk of myocardial infarction and death. This looks like the true answer. E. 38E. So, but I'll need clarification with this and maybe more explanation. Thank you. Hello.
Hello, Dr. Ayodele.
So
Hello,
that's 38.
call upon you again. Chief Kweki, please, are you there with us? Or Chief Okopi? or anybody on the platform that can give us more clarity on the question.
Ivokopi said he's having network issues.
Yeah, so I hope it's not his village people again.
I think that's from the last season of this endeavor. At times, it's actually necessary to read. Yeah, there are some that are straightforward, but there are actually instances where we may have to read from the answer provided by Braunwald to have a better picture. Alternatively, we can also go online and do quick research on that topic, because especially questions is actually very topical. So I think
I agree with you. I think we should read the option to make it clearer.
Dr. Precious, please can you quickly go to the answer?
Question 38.
Thank you, Chief Ajayi.
You're welcome.
Thank you, Dr. Precious. So please, I will just go ahead and read answers to question 38.
You can always also, sorry, man, I just wanted to suggest so that you also don't feel exhausted or alone. You can also call on anyone to also read, so that it's not as if you are stressed to do that all the time. So I just want to say it's optional.
Thank you, Chief Ajayi. You trust me. I'll call out. But let me just take this so much. So assessment, the correct answer that they picked here was E. So I'll read assessment of coronary artery calcification is a surrogate marker for coronary atherosclerotic plaque. The correlation between the amount of coronary calcium and the actual angiographic severity of the CAD is weak. The complete absence of coronary calcification on EBT has a strong negative predictive value for high-grade coronary stenosis, but does not completely rule out the presence of significant coronary artery disease. The Agatston score is the most frequently used system for reporting the severity of coronary artery calcifications, and reference data set for interpretations are stratified by age and gender. I think that one answers one of the options. Annual rate of myocardial infarction or cardiovascular death rise with increasing Agatston score, even in patients with similar familial risk scores. Sorry, I didn't get that. Annual rate of myocardial infarction or cardiovascular death rise with increasing Agatston score, even in patients with similar familial risk scores. Okay, I got that. Coronary EBT is of most clinical value for patients who are at intermediate risk for coronary events based on traditional cardiovascular risk factors, and for whom an abnormal scan will have an impact on clinical management. I think Dr. Ayodeji already explained that. Reading it now, I think it's a little bit clearer. I don't know whether there is any other part that is still gray, or if there's another person that have additional comments. Dr. Ajayi.
Ma?
Yeah. I think it's clearer now, right?
Yes, ma'am. It is.
Okay.
It is.
I
Thank you.
think okay. Thank you too, sir. Dr. Ayodeji, I
Okay.
believe you can continue.
Okay, thank you. So question 39. Which of the following statement is true regarding prognosis as determined by myocardial perfusion imaging? Okay. So A, patient with normal perfusion in the presence of angiographically documented coronary artery disease have very low rates of cardiac events. Okay. I think I will skip I'll go to the next one. Silent imaging results in a less breast attenuation artifact compared with technetium 99. This is false. It's the other way. It's the technetium. It does result in the more breast compared with the technetium 99. So this is a false statement. Let's see. The transient ischemic dilatation of the left ventricle and long uptake of the nuclear tracers are common findings in normal individuals. In fact, when you have following an ischemic myocardial ischemia from an MI, of course, you could have a dilatation of the left ventricle, and you tend to have more increased lung uptake of the nuclear tracer, which is an abnormal finding. It's not a normal, which suggests an abnormal finding following an MI. So you don't find that in a normal individual. You only find in patients coming from a patient following an MI, and the way you do an imaging perfusion studies following an MI, you have an increase using either the SPECT or the PECT. So this is also false. The combination of clinical and cardiac catheterization data is more predictive of subsequent cardiac events than the combination of clinical and myocardial. This is false. In fact, the myocardial perfusion is more suggestive of predictive of subsequent cardiac events compared with clinical and the CAD. So this is a false statement. The risk of future cardiac events is unrelated to the number or the extent of, even from the D option, this is also false. It's very related to the number and the extent of myocardial perfusion defects. But I think A is true. A is true. A is the true option here. Other ones are false. Thank you. Hello? Hello?
Hello, hi.
The question, the clarification.
Sorry,
think
how did you explain the C option? The options.
Well, I think with when you have when there's an increase in the lung uptake of the nuclear tracers, is an abnormal finding.
Okay.
Yeah.
Okay.
Increased uptake in the lung uptake is an abnormal finding. So it's not a normal finding, the normal infection.
Okay. Thank you.
Yeah. Okay. Thank you.
Please, let's continue.
Okay. The question 14. A previously healthy 29-year-old man presented to the hospital because of 1 month of progressive exertional dyspnea, weakness, and weight loss. One day before hospitalization, he was unable to climb 1 flight of stairs because of shortness of breath. On the examination, he appears fatigued with mild respiratory distress. His blood pressure is 110/70 millimeter of mercury without pulsus paradoxus. His heart rate is 110 beats per minute and regular. The JVP are distended, jugular veins are distended without the cosmos sign. Pulmonary auscultation review, scans by basal rails, and the heart sounds are distant. There's a mild bilateral ankle edema. As part of the evaluation, he undergoes cardiac MRI image, cardiac resonance imaging. A short axis view at the mid-ventricular level is shown in figure 1.8. Which of the following is the most likely diagnosis?
Chief Adikolaide, would you like me to go to the figure?
Okay.
Is that okay?
Yeah.
I thought they said figure 1.8.
Yeah, so if 1.8, this is not 1.1.
This is
Okay,
1.8.
yeah. Well, I really don't. Well, what's from the negatives we have here, of course, it rules out the constrictive pericarditis. We found that we have absent pulsus paradoxus, cosmos sign, rules option C out as the likely diagnosis. And so this image, I really positive. But there's a mass extending into the right ventricle, just surrounding the, like a pericardial mass, but also extending into the right ventricle and all that.
Well,
But I really don't know what exactly it is, but of course, I can exactly get with the progressive weight loss. Of course, it's progressive weight loss. If patient has a TB pericarditis, I mean, causing maybe constrictive pericarditis from tuberculosis, because they could have severe weight loss too. And then from malignancy too, yeah, in the pericardial mass, because there could be progressive dyspnea, weakness, and also weight loss too.
Yes. Good evening. I think we can, yes, from your guess, we can actually tease it out. If we look at the imaging, just like you said, okay, we've identified the left ventricle, the right ventricle. And of course, we try to, what are the things that the CT actually delineates more? The pericardium. So looking at the pericardium, we'll note that aside the left ventricle, we can see the left ventricle is not big at all compared to the right. I don't know. I'm not used to this view or reporting CTs too, but we'll notice that the myocardium now of the left ventricle has the same consistency as what we presume to be part of the pericardium. I'm not sure if you are seeing what I'm seeing. After what's where we expect to see the pericardium now to be thickened if we are looking for constriction. We are seeing like yes, we are seeing like something surrounding the heart, which takes the same consistency as we have as the myocardium. So that first guess, we can do that. Then obviously we know that we cannot really appreciate any constriction here. The the signs that we're giving rules out constrictive pericarditis, and we are not even seeing any brightening of the pericardium here. So that rules it out. Then talking about this chronic organized pericardial hematoma, what do we expect in an hematoma? Hematoma, we expect it to take the consistency of what we have as blood, which should be black, and it's not black here. Do you understand? And even if it's a chronic one, we expect if it's calcified, you should see calcification that is brightening, just like we see for constriction, which is not here. So as adding the guess, I don't think it's an hematoma either. We talked about extracardiac tumor compressing, extracardiac tumor compression of the heart. If we are thinking of an extracardiac tumor compressing the heart, it won't be. This is just as if the heart is encased. It's not on one side. So if it's one side now that we are seeing it, we will think of maybe the compression or maybe the tumor in only one side. So it's around the heart. So it's encasing the heart. So compression of one side might not be congenital partial absence of the of course we can, there's no absent pericardium here. So I don't think E is the answer. D might not be the answer. We ruled out C, B. So the answer might be pericardial malignancy, actually, with the weight loss, muffled or distant heart sound, as the case may be, and absence of signs to suggest constriction. So I think it's A.
Thank you. I think that concludes us.
Thank you. Welcome, sir. Sir, good evening, sir.
Sorry, good evening. So I didn't know I was unmuted. Sorry, guys. Sorry.
You're welcome, sir. Okay. I also think that is a primary cardiac malignancy from the option, and it has been well explained. Sure. If there are no further comments, Dr. Ayodeji, I think this is the end of your own part.
Thank you.
Thank you, sir. So I think we should move on.
Thank you, Dr. Ayodeji.
Yeah.
You're welcome.
I think we should move on to the next person on the list, Dr. Alagbe. Questions 41 to 50.
Okay. Good evening, everyone.
Good evening, you're welcome.
Thank you. So I'll be taking 41 to 50. So, which of the following statements regarding intracardiac shunts is correct? A left to right shunt should be suspected if the difference in oxygen saturation between the superior vena cava and the pulmonary artery is 3% or more. Okay, this is actually false. A left to right shunt should be suspected. Okay, sorry. Normally, when you want to measure the oxygen concentration, you measure it most times at the level of the pulmonary artery, because this is where there's complete mixed venous oxygen content. So the different veins draining into the right atrium, they come with different oxygen concentration. So by the time they are moving to the lungs in the pulmonary artery, they get completely mixed up. So that's why it's good to measure here. That's if there's no shunt at all. That's why it's good to measure here most times. That's if there's a left to right shunt, it's good to measure it here. So if the difference is like, if the oxygen saturation is like 8% or more, that is when you should suspect a left to right shunt, not 3%. So that makes this false. Then option B, oxygen saturation in the superior vena cava is normally higher than that of inferior vena cava, is false. Oxygen concentration in the inferior vena cava is higher than superior vena cava. Okay, normally like about 3 things drain into the right atrium: the superior vena cava, the inferior vena cava, and the coronary sinus. And the variation in their oxygen content is like 2%. So inferior vena cava still has the highest oxygen content. So not superior, so false. Then in a suspected atrial septal defect with left to right flow, mixed venous content should be measured at the level of the pulmonary artery. Okay. Option 1, I said normally if there's a left to right shunt, normally it's being measured at the pulmonary level or the left ventricular level. But now if there is a shunt in between the atrium, you want to measure proximal to the shunt. You want to measure proximal to the shunt. So you want to measure at the atrial level. So if there is a shunt, atrial septal defect with a left to right shunt, you won't want to go as high as pulmonary level. You want to measure proximal to the shunt. So this also makes this false. Then the next option is a pulmonic to systemic blood flow ratio greater than 1 indicates a net right to left shunt. This is also false. Now, the pulmonic to systemic blood flow ratio, if is equal to 1, that means it's normal. Then if it's less than 1, what it means is that the pulmonary blood flow is less than the systemic blood flow. So that means blood is moving from the pulmonic side to the systemic side. That is why it is less than 1. So it is a right to left shunt. If you have a value greater than 1, that means there's more pulmonic flow than systemic flow. So that's why it's greater than 1. So what it means is that blood is moving from left to right. So for this one, greater than 1 should be left to right, not right to left shunt. So that's why it's false. Then option E, pulmonary artery oxygen saturation exceeding 80 should raise suspicion of a left to right shunt. So this is true. Normally, if there is a left to right shunt, we know that pulmonary artery carries mostly deoxygenated blood, and it shouldn't be up to 80, it should be less than 80. But by the time you're seeing it greater than 80, and there's no any other cause that you can attribute it to, then you should think of
a shunt, a left to right shunt. Any other contribution? I'm done with 41.
Please, any contribution or comment? I think your explanation is clear though, but please further clarification and comment. Prof, sir.
You explain that option C.
Wow. Prof, your network, sir. Hello, Prof, sir. Hello, Prof, your network is unstable, sir. Hello, Prof. Okay. His network was unstable. Is any other comment from anybody before Prof joins us back? Dr. Ayodele, are you commenting, please?
No.
Okay. Okay. Please, Dr. Alagbe, let's continue. Once Prof joins us, he makes his comment. Thank you. His network was.
Sorry. Option C.
Okay, thank you.
Yes, sir. You're back, sir. Thank you, sir, Prof. We can hear you now.
Can you explain option C?
Okay, I said option C, in a suspected atrial septal defect with left to right shunt, mixed venous content should be measured at the level of the pulmonary artery. I said this is false. Normally, if there's an ESD, you should measure the mixed oxygen content proximal to the shunt. So that's why it's false. So we should measure it proximal to the shunt, not after the shunt.
So what's the mix? What's mixed venous oxygen?
Pardon? Okay, mixed oxygen is just mixed venous oxygen is the oxygen content after the tissue has been perfused. So we calculate it using what they call the FLAM formula, and is equal to 3 times SVC plus IVC divided by 4. So that's how we get the mixed oxygen content. So it's just the oxygen content after tissue perfusion.
Yeah. So why did they use 3 times SVC?
Okay. That I didn't check. I just checked the formula. Actually, I didn't check for that.
There's always a reason for everything now. So what if the patient has an interrupted IVC? What would you have done?
The patient has an interrupted IVC. So that means I'm going to use the SVC.
So we're going to use the SVC only because it does not have an IVC. That's the meaning. Okay.
Yes.
Yes. So will you now be doing 3 times SVC?
Pardon?
So will you now do 3 times SVC following the formula?
That's what I think, but I don't know.
I want you to get the question well. So the patient has interrupted IVC. Okay, and the formula says 3 times SVC plus IVC divided by 4, right?
Yes.
So we are now saying the patient does not have IVC. What are you going to do? Will you still take, you said you will now use SVC sample, right?
Yes, I'll use SVC sample.
So the question now is, will you still do 3 times SVC?
Okay, I get it. No. Maybe I will. Maybe I'll multiply it by, I'm not too sure. I'm just doing a guesswork. I'm thinking I will not multiply it by 3. Maybe I will increase it to 4 or 6.
I don't know. You would multiply by 6 or increase it. I didn't get that. That's 4 or 6. What do you want to do with the
I
4 or
said,
6?
okay, I don't know. I don't have an idea. I said I'm just doing a guesswork. It's
Yeah,
either
I
I
get
will
you.
do 4
I'm trying to follow your guesswork too. That you said 4 or 6 as in. So what would you do to the 4? Are you multiplying by 4? Are
Yes,
you
I will multiply 4 by SVC, 4 times SVC, or
okay?
6 by SVC.
And then what will that do? Were you going to divide by any value? So let's say you're using 4. So 4 times SVC, then you divide by what? Or you not divide?
I'll still divide by 4.
Okay, so let's put mathematics together. So let's say SVC sample is 98. Sorry, 60. Let's say 60%. Okay, so you do 0.6 because you convert to decimal place. So 0.6 times 4 divided by 4. What do you think you will get?
0.6.
Exactly. So I'm wondering why you're still going to now say you want to multiply by 4 or by.
Okay.
You get it now?
Yes. Yes.
Oh, okay. So technically, so mixed venous oxygen is the reason why they have to do mixed venous oxygen is because you want to get the total desaturated oxygen that is entering the right side. That's the right atrium. Okay. So there are 2 ways to get it. In a patient that does not have a shunt, okay, let's say the patient does not have a shunt. So it simply means that, blood is coming from the upper limb and the brain, it will pass through the SVC. Blood is coming from the lower limbs and the other abdominal organs, it will pass through the IVC, right? So they have to be mixed together, right? So we have 2 ways to assess in order to get the total saturation that is entering the right atrium. So it's either we take samples both from the SVC and IVC and do a mean of it, okay? Or we go to the pulmonary artery and take the sample. And why? We take the sample in pulmonary artery because we expect that the blood coming from SVC and IVC will mix together in the right atrium. They will mix together in the right ventricle, right? And that's the same blood that will get to the what? Pulmonary artery. Do you get that?
Yes.
So that is only reasonable, acceptable when there's no shunt. It's only acceptable when there's no shunt. So for example, let's say you just want to calculate cardiac output in a patient that does not have a shunt. So you expect that the QP will be equal to QS because there's no shunt. You get that? So in that case, you don't need to do SVC plus IVC. All you need to do is just go to pulmonary artery and get the saturation in the pulmonary artery. But when there's a shunt, we both know that the mixture of SVC and IVC will be affected by the shunt if you go to the pulmonary artery, because blood will have shunted from the left atrium or left ventricle into the right, and that is an oxygen-rich blood. So whatever you will get in the pulmonary artery will be a falsely elevated saturation. Do you get that? For a mixed venous oxygen. So in a patient that has a shunt, the only option you are left to is to take the sample from the SVC when it is close to the right atrium, and the IVC when it's also close to the right atrium. Make sure your catheter looks away from the hepatic vein so that you'll not be taking a hepatic vein sample. So just be sure that it's SV sample and IVC sample. Then you are going to do a mean for it. And the calculation is, as you said, is either you do a 3 times SVC plus IVC divided by 4, or you do 2 times SVC plus IVC divided by 3. So why do they put that multiplication of 2 times 2 or times 3? The reason is because the brain uses more oxygen than every organ of the body. So the brain consumes more oxygen from the blood system. So you get more desaturated sample from the brain. So in order to correct for the error, if you take SVC, single sample of SVC, that's why you multiply, because the brain uses more oxygen. So you need to account for that drop. So scientifically, or theoretically, it looks correct, but scientifically, it might not be actually correct. You get, but theoretically, it looks that, okay, this organ uses more oxygen. So let's account for the excess desaturation. That's why they multiply. Okay. So, and that's why IVC is, SVC would have lower oxygen than IVC. So that answers your question number B. SVC will have lower oxygen than IVC because the brain has used most of the oxygen. Okay, so so the mixed venous oxygen is that of SVC and IVC before getting to the shunt. That means you take it as they are entering into the right atrium. So now, if the patient has a interrupted IVC, that means he does not have an IVC at all. So most of the blood will pass through the zygous vein and it will drain into the SVC or coronary sinus. So the answer to that is just to take the SVC sample, or you go into the right atrium and take the sample. You get? So if you are using only SVC sample, you need to be using the formula because you still get the same result. Because most of the blood will drain from the zygous vein into the SVC. So why are we now multiplying again? Okay. So in simple terms, when a patient has interrupted IVC, they don't have a congenital abnormality. They don't have an IVC. So all the blood
half at night.
You said? Hope I'm still audible.
Very audible, sir. Thank you so much for the.
It means the interrupted IVC. It means all the
blood
and the intestine
to
the into the SVC. So all the sample you need to collect is a sample from SVC because they're already mixed together there. Thank you.
Okay. Thank you, sir.
Thank you so much, Prof. Thank you so much. Very, very clear. Thank you. Let's go to the next question.
Okay. A 46-year-old man with dyspnea on exertion is noted to have a systolic ejection murmur along the left sternal border. An echocardiogram is obtained. Figure 1.9 shows Doppler pulse wave interrogation of the left ventricular outflow tract, recorded from the apex. Which of the following recommendations will be most appropriate? A. Strict fluid restriction. B. Avoid volume depletion. C. Aortic valve replacement. D. Bed rest. Okay. By looking at figure 1.8, we can see that this is what is being seen in hypertrophic obstructive cardiomyopathy, which is called the dagger pattern, and is just it's a description of the LV tract, LV outflow tract, that it shows late peaking of systolic acceleration. So as we can see, it peaked lately. That's the image down, the down parts of the image. We can see that it's a late peaking systolic acceleration. And this dagger pattern is just due to progressive reduction in the LVOT size. So as blood is being pumped out, there's a reduction in left ventricular volume, and the LVOT too reduces. So that's why it's giving this pattern. So this is seen in HOCM. So now, strict fluid restriction is false. Okay, sorry, let me explain something again to pick the In HOCM, normally anything that increases preload, that increases venous return will anything that increases venous return, or no, sorry, anything in HOCM, anything that decreases venous return will decrease left ventricular volume. By decreasing left ventricular volume, that means there will be a narrow space between the hypertrophic septum and the anterior mitral valve leaflets. So it's going to worsen the outflow tract. So in this case, you don't want anything that would deplete the volume or anything that is going to decrease the preload, that will now lead to decrease in left ventricular volume, because it's going to worsen the outflow tract. So coming back to the options, so strict fluid restriction is false. Avoid volume depletion, that's the true option, because we don't want the preload to reduce, because it's going to worsen the obstruction. Then C, aortic valve replacement is false, because it's not an aortic valve problem. Then bed rest is false. I don't know whether we're okay with the explanation.
Please, any further comments or clarifications? I think the explanation was good, but I don't know whether people have comment. In the absence of none, maybe we should just move on. Thank you.
Okay. 43. Which of the following statements regarding echocardiography in pericardial disease is correct? Small pericardial effusions tend to accumulate anterior to the heart. This is false. Small pericardial effusions gravitate to the left ventricle. They tend to accumulate posteriorly around the left ventricular free wall. That's where because of the way the heart is seated, so the fluid will gravitate down, so it will go posteriorly around the left ventricle, so they don't stay anterior. Option B, up to 100 mils of pericardial fluid is present in normal individual. This is false. Normal pericardial fluid is within 30 to 50. So by the time we're seeing 100, that means it's pathological. 3, in cardiac tamponade, right ventricular diastolic collapse occurs less frequently if pulmonary hypertension is present. This is true. Yesterday we discussed about it. Right ventricular diastolic collapse is actually a specific finding for cardiac tamponade. So if there's pulmonary hypertension, or there's right ventricular dilatation, that will tend to counterbalance the increased intrapericardial pressure that is causing the diastolic collapse. So it's as if it's opposing what is coming from the pericardial cavity. So we may not see the diastolic collapse we're looking for on echo. Then D, in the presence of pericardial effusion, right atrial diastolic indentation is a more specific sign of cardiac tamponade than early diastolic collapse of right ventricle. This is false. Right atrial diastolic indentation is more sensitive, but it is not specific. E, transthoracic echocardiography is superior to chest CT as a means of accurately measuring pericardial thickness. This is false. CT is superior to echo, and cardiac MRI is the best for checking pericardial thickness. Any contribution?
Hello. Dr. Alagbe.
Yes.
I think we should continue. There's no comment.
Okay, thank you. 44. Which of the following statements regarding nuclear imaging in cardiac disease is true? The use of SPECT with ECG gating has no impact on the specificity of nuclear testing in women with attenuation infarct. This is false. They said yesterday, as we said, as Prof told us, PET is better than SPEC. PET takes care of attenuation infarcts. So in order to improve SPECT in avoiding this attenuation infarct, if we use ECG gating, is going to reduce the amount of false positives we're going to get as a result of breast attenuation. So that makes this false. Then B, exercise nuclear stress imaging rather than pharmacological stress testing is preferred diagnostic modality for patients with right bundle branch block. This is also false. If we remember, indications for pharmacological stress testing, one of them is once the baseline ECG is abnormal. Abnormality like left ventricular hypertrophy, left bundle branch block. Because if we do exercise stress test, it's going to give us an exercise-induced artifact. So that's why pharmacological stress is preferred in right bundle branch block. Then C, the presence of reversible defects on pharmacologic stress perfusion imaging before non-cardiac surgery predicts an increased risk for perioperative cardiac events, but the magnitude of the risk is not related to the extent of the ischemia. This is also false. It said that the pharmacological stress perfusion imaging before any non-cardiac surgery. That means maybe this person is at intermediate risk, and now the person wants to go for a non-cardiac surgery, and you want to place the person, you want to be safe whether the person is low or high. So when you do pharmacological stress test, is going to predict whether the patient is at increased risk of cardiac events, and the magnitude of the risk is directly related to the extent of the ischemia. So the later part of the option is the one that made it false. So the magnitude of the risk correlates with ischemia. Option D, cardiovascular events rates are similar in diabetics compared with non-diabetics for any given myocardial perfusion abnormality is also false. Cardiovascular event rate is higher in diabetics than non-diabetics. Then E, viability of non-contracting myocardium can be accurately evaluated by thallium-201 imaging. This is true. Things that help to evaluate viability of non-contracting myocardium, one of them is thallium-201 imaging. Another one is dobutamine echo. Then there's cardiac MRI. These are things that help to check the viability of non-contracting myocardium. Any contribution? Can I go ahead?
Yes,
May I
please.
ask you just a quick one? So, because you can see an MCQ tell you, hope I'm audible.
Yes, Prof, you're audible,
Yes,
sir.
You can see an MCQ that can ask you the agents used for nuclear radionuclear imaging. So, which agent?
Okay. Okay. We have adenosine. Adenosine is a coronary vasodilator. It acts on the A2A receptor. Then we have dipyridamole also. It inhibits the enzyme that mops out adenosine. That's adenosine deaminase. Then we have, there's one, is it adenosome or something? I can't remember. Yes, adenosome. It's also a direct coronary vasodilator. Those are the FDA approved. Then I think I saw dobutamine, which is not FDA approved. They use this for, they are the vasodilators used for pharmacology testing.
Hello, Prof. Any further comments, sir? Prof, sir.
Sorry about the network. So I guess you meant regadenosin.
Regadenosin. Yes.
Okay. All right. So those are pharmacological agents, pharmacological for pharmacological stress tests. I need to get the question well. Radionuclear imaging test. Radio. So that means they have to be active agents.
Okay. Radionuclear. There's a technetium 99. I don't know whether those are what.
Hello. Hello, Dr. Rabi.
Yeah, I'm here.
Okay. If there are no further comments, I think we can continue.
No, but he was trying to tell us something about the radionuclear agent.
Yeah. So
Okay,
we're
yes.
trying
Let's
to look at the radioactive agent because an MCQ question from Prof. So you need to know the radioactive agents used. So as she said, section 99 is one. Then thallium is also another one. Rubidium is another one.
Please come
Ammonia.
again with the
Sorry,
name.
what's the third one, sir?
The
The
third
third
one.
Yeah,
Yes.
Yes.
rubidium. 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 Okay. Then ammonia is another one. And I think the last one is there is also kind of it's like H2O, but it's like an oxidized H2O. It's an oxidized H2O, so it can be used. So the two that is used by SPECT is the thallium and technetium. There are others also, but the other three I mentioned, which is ammonia, rubidium, and oxidized H2O, is used by PET scan. So these are at least MCQ questions that can come out. You should know the advantage of one over the other. Okay. Technetium is preferred over thallium because it stays longer in the blood system, especially when they are doing SPEC that can take many hours. In fact, the procedure can take up to 24 hours. So it has a longer half-life. Okay. PET is preferred because it has better accuracy, better specificity. There's no false attenuation. There's no false positive results because there won't be attenuation of the imaging. Okay. PET, you can use it to quantify flow, coronary blood flow or coronary flow reserve. You can quantify it, the percentage of flow across the vessel. That you will not get with SPECT. Okay, it's faster. You achieve your result far more faster, shorter duration than SPECT. Okay. So then you should know the different tests that can be used for assessing myocardial viability. All these procedures are just for myocardial viability. So you should also know which other procedures can be used for assessing myocardial viability. They are important questions or can come out in Viva. Thank you.
Thank you so much for Dr. Alabi.
Yes, I'm here.
Yes.
Okay, I should continue.
Yes.
Okay, 45. Oh, I don't know this one. No. Okay, a 45-year-old woman was referred for exercise echo because of a history of intermittent chest pain. She has a strong family history of premature coronary artery disease, but no other atherosclerotic risk factors. The exercise echo achieved the desired heart goal and demonstrated a focal wall motion abnormality of the left ventricular anterior wall at rest, which was unchanged at maximum exercise. A subsequent cardiac MRI study was performed to characterize the myocardial tissue in that region. A delayed image taken after IV administration of gadolinium is shown in figure 1.10. What is the most likely cause of the anterior wall abnormality? So figure 1.10. I will need Prof's help with this because I don't even understand the explanation they gave. But the answer is B, prior MI.
Can you please read the options out?
Okay. Transient myocardial ischemia due to significant coronary artery stenosis, prior myocardial infarction, myocarditis, infiltrative cardiomyopathy, breast attenuation infarct.
Thank you so much. Please, Prof, we've come again. Oh, we need your help, sir.
The solution to this is to look at the image itself.
Yes, sir. We are not so conversant with the image, sir. That's why we need you, sir. Thank you, sir.
No, so the image is not hard though. It's just like you see we do echo. Okay, thank you. I appreciate the person zooming into it so that it can be clear. And see, it's like the way you do echo. So the one important thing you should know about cardiac MRI is that it gives you the same cut, the same view you're going to do in echo. Either is a long axis, the apical 4, the apical 3, you will see apical 2, short axis. You also see at the both at the aortic level and LV or mitral level. It's the same view. So it's the same way you look at echo. So it's not hard. So that no matter, even if they bring it out, no matter what they bring out, it's the same way. They look the same. Okay. So now they are giving us a short axis view at the papillary module level. So they've helped us to label it LV and LV. So I usually tell our residents it's important to know that the right chambers are anterior to the left chambers. So that means the right atrium, right ventricle is anterior and to the right of in the mediastinum, while the left atrium, left ventricle is posterior to the left. So that means, so looking at this sagittal view, now this is actually a sagittal cut. you would see, even though it's an MRI, your left hand side gives you close to the center. Okay, that means you're looking from the front of the chest backward. Your right hand side going to the back, you'll be able to see the vertebral bone. I don't know if they can put an arrow to show the vertebral, but at least we've seen vertebral spine on MRI before. So you can the person in charge of the screen help us put an arrow?
Dr. Precious, can you help us put an arrow, please?
Yes, so that we can be following, yes, with the arrow. So I want you to put the arrow at the spine.
Sir, where at the book?
So you see that where you have now, that's where the spine is. Okay?
Okay, sir.
Are you getting it? Now, so that you can see there's a push. This is a sagittal cut. Okay? That means they're cutting it from, you're splitting the patient into two. Okay? So this is a sagittal cut. So you can see the spine there. So that means that you can see the chamber that is close to the spine and the level for you LV. So you can see it's posterior to the RV. So RV, so right chambers are anterior and to the right, left chambers are posterior and to the left. Okay. So one important thing, so what they want you to focus on is the late gadolinium enhancement, which we call the LGE. So you can see the septum, interventricular septum separating the RV and the LV. You can move your arrow there. Yeah. So you can now see that white patch. So you can see that white, so that is the late gadolinium enhancement around the septum, and go more superior, you see that looks like the anterior wall, right? So that's why we say it's anterior septal. Hope you get it. Okay. Now
Yes,
the second important thing you should know is that it's not the white part is not occupying the whole of the septum. That means it's not transmural, meaning that you can still see some black parts above the white part, right?
Yes, Prof. Yes.
Yes. So yes. So it tells
Yes.
you that. So that tells you that is a subendocardial infarct.
Oh.
Okay. If the white part was totally occupying the whole thickness of the interventricular septum, you say it is transmural. Okay. That's how you differentiate a subendocardial from a transmural infarct. So in this kind of patient, you should have a revascularization because it's still subendocardial. If it was transmural infarct, transmural scar, then revascularizing it would not make any difference because already. Hope you get that. So that is one importance of using a cardiac MRI to determine viability. You want to differentiate a subendocardial infarct from a transmural infarct. Hope we get that. So the other part you should now get is that you see that white part. Imagine if it was within the interventricular septum. Simply, so get it very well. So simply saying that you see the interventricular septum now, it's actually within the interventricular septum, close to the LV, right? But I want to paint another scenario for you. So let's say you put that white part in between the black part of the interventricular septum, meaning that below the white part, there's a black part. Above the white part, there's a black part. So meaning that the white part is now in the middle of the muscle layer. If the white part is within the middle of the muscle layer, then you'll be thinking of sarcoidosis or infiltrative cardiomyopathy. So imagine you are putting the white part in the middle. So before it, there's black. Above it, there's another black muscle. So that you now say that's an infiltrative cardiomyopathy. Do you get it?
Yes,
it could also pass for myocarditis. Okay, if it's in that lane. Now, if you now put the white part at the outer layer, let's say the white part is in the outer layer. Let's use the posterior wall, for example. You can move your arrow to the posterior wall. Exactly. So let's say the white part is in the outer layer of the muscle. So move your arrow to the outer layer of the muscle.
Outer layer, yes, sir.
Okay. So let's say you have, no, that's inner layer now. You are close to the
That's
chamber.
outside, yeah. Sorry.
Outer layer of the muscle. Let's say you are seeing the white part in the outer layer of the muscle. So that could be myopericarditis because it's close to the pericardium. So that is not an infarct. So I've given you two scenarios that is not going to be an infarct. One, if the white layer is in the middle of the muscle. Two, if the white layer is closer to the pericardium, then it's not an infarct. Okay, so an infarct would either be subendocardial, meaning that the white layer is close to the chamber, the lumen, or it is involving the whole layer of the muscle. That is when that is in two parts that can be infarct. It's either it's transmural or it's subendocardial, not epicardial. Hope it's clear.
Yes, Prof. Very, very clear, sir. Thank you so much.
sir.
Just note that this can only be seen on MRI, not on CT. So that is why MRI is a test for viability, not CT scan. Okay, thank you.
Prof, thank
Yeah.
you.
Thank you,
Hello,
bro.
sir. Thank you so much, Prof. So, sir, is this subendocardial or transmural? I'm so sorry, I'm getting back.
So question is asking if this image we're seeing, this late ganglion enhancement we're seeing, if it's subendocardial or transmural, right? Is that your question?
Yes, sir.
Yeah, so I want you to get the, okay, so let's do something. Let's make something clear. So you see where the arrow is now? You know, it's on the white part, right?
Yes, sir.
So that is a scar. Okay. So the real muscle, so if you can move your arrow a little bit above the white part. So the real muscle is the black part. Okay, that's the viable muscle. Okay. So late ganglion enhancement.
Hello, Prof. Hello, Prof, sir. Okay. Please, am I audible?
Yes, yes,
Yes.
sir.
Okay. Please, let's wait for Prof. Maybe the net is network. Hoping that I will join soon. Join back soon.
I've been able to reorder my network. I think you should hit the ground running. Sometime it may take a while for it to connect, so that we can save time. When it comes back, we can revert back to the
Go
question.
back to the question. All right. Thank you,
Yes,
Chief.
yes. Mm.
Thank you. Dr. Alabe, please continue.
Okay, 46. Which of the following statements concerning the echocardiographic evaluation of aortic stenosis is true? The peak-to-peak gradient measured at cardiac catheterization routinely exceeds the peak instantaneous aortic valve pressure gradient assessed by echocardiography, Doppler echocardiography. This is false. It's been said that measurements gotten from echo is well validated when you compare it with that gotten from cardiac catheterization. Patients with impaired left ventricular function may have severe aortic stenosis as determined by continuity equation, despite a peak outflow velocity of only 2 to 3 millimeters per second. This is true. The first presenter was saying something earlier about aortic stenosis. Patients that have severe aortic stenosis, that's the valve orifice of less than 1, but still they have a mild gradient, because if you look at 2 to 3 falls, when you want to look at the mean gradient, this is like mild. This is happening because they have impaired left ventricular function. Most times their LV ejection fraction is less than 50. So they are classified as low flow, low gradient, despite having severe aortic stenosis based on the valvular area. So if you want to get a higher peak velocity across the valve, then you may subject patients like this to dopamine echo, where you give them dopamine, they need to increase contractility, and LV function will improve. Then you'll be able to get a higher velocity across the valve. Then C, among Doppler techniques, the most accurate
Sorry. You meant dobutamine or dopamine?
Sorry, dobutamine. Dobutamine. Okay. Dobutamine echo. Thank you. Among Doppler techniques, the most accurate trans-aortic valve flow velocity in aortic stenosis is measured by pulse wave Doppler imaging. This is false. Once you want to measure trans-aortic valve flow, you use continuous Doppler, not pulse. Then D, the greatest degree of error in calculation of aortic valve area using continuity equation resides in inaccurate measurement of the trans-aortic valve flow velocity. No, this is false. They said the greatest error that is made in measurement of aortic valve area is when you don't measure the LV outflow tract accurately. So this is dependent on who is doing the echo. So that's the greatest error you can make. And we know that we need this LV outflow tract measurement in calculating the size of the orifice using the continuity equation. Then, okay, sorry, the continuity equation is just is A1 V1 equal to A2 V2. So A1 is the area around the LV outflow tract. Then V1 is the volume. Is the velocity around the outflow tract. Then V2 is the area around the orifice, and then the velocity around the orifice. So you input whatever you get, then you'll be able to calculate the area of the orifice. So if you are picking A2 as the area of the orifice around the aortic valve, so you input other things that you got, then you'll be able to get that. So option E, the mean aortic valve gradient measured by Doppler echo is typically higher than the mean gradient measured by cardiac catheterization. This is false. It's almost similar to the first thing I said. Any addition?
Please, let's hit the ground running.
Okay. 47.
Yeah.
Which of the following statements regarding assessment of intracardiac shunt during cardiac catheterization is correct? A, in normal subjects, there is no difference in oxygen content in different parts of the right atrium. This is false. We've explained it earlier. there's oxygen difference of about 2%. So Prof explained IVC has higher than SVC, then some contribution from coronary sinus also. B, because of normal variability in O2 saturation, shunts with pulmonary to systemic flow ratios of less or equal to 1.3 at the level of pulmonary artery or right ventricle may escape detection by oximetry run analysis. This is true. This is true. It said that earlier I said once you have pulmonary to systemic flow ratio of greater than 1 is showing that the shunt is from left to right. Now, when it's left to right, that's greater than 1, there's still some form of grading. If it's greater than 2, that means the left to right shunt is significant. And those are the kind of shunts that need closure. Then if it's less than 1.3, 1.5, it's telling you that it's a small defect, a small left to right defect. And this kind of shunts can be omitted during cardiac catheterization. So that's what this question is just trying to say. So this is true. 3, C. When a shunt is bidirectional, its magnitude can be calculated as the difference between the pulmonary and systemic blood flow. That's QP, QS, as determined using the Fick's equation. Okay, this is also false. This formula QP minus QS is used for unidirectional. That's if we are not using the ratio, that's QP all over QS. We can also use QP. We can use QP minus QS. So if you look at this equation, it can also help you to say whether it's a left to right or a right to left. So for example, if pulmonary blood flow is more than systemic blood flow, that means you get a positive value. That means the shunt is left to right. Sorry, can you hear me?
Yes,
Yes.
yes.
I hear you.
Okay, it's echoing here, so that's what I'm thinking.
Yes, I'm
Okay.
making everybody that their mics are on already.
Okay. So I was saying that if pulmonary blood flow is higher than systemic, we'll get a positive value. So it's still telling us the same thing from that equation. If the P is higher than the S, we'll get greater than 1. So this one, we're going to get a positive value. So it shows that is a left to right shunt. Then if we get a negative value, that means pulmonary blood flow is not as much as systemic, meaning that most of the flow from pulmonary is entering the systemic. So that means it's going from right to left. So this formula is also used for unidirectional. This Fick equation is just an equation that is used to calculate systemic blood flow and then pulmonary blood flow. Then you now come and input it into this formula and then get whatever you want. I don't know whether I should give the formula for the Fick's equation. Is cardiac output is used to calculate oxygen consumption. So is cardiac output times AV oxygen content difference. So when we get the AV oxygen content difference, then we'll now multiply it by cardiac output. So this is the Fick's equation. It's used to calculate systemic blood flow and it's used to calculate pulmonary blood flow. Then option D, in patients with pure right to left shunts, the QP over QS ratio will be greater than 1. This is false. It will be less than 1 because the chamber that is receiving the blood will have a higher value than the chamber that is giving the blood. So this is also false. So B, option B is the correct one for question 47. Any contributions? Okay, 48. Which of the following findings during an exercise test is not associated with a multivessel or left main coronary artery disease? So, okay, let me just say the findings that indicate is severe coronary artery disease or multivessel. So 1, if there is early onset of ST depression in stage 1 of the Bruce protocol, it shows that it's a severe coronary disease, either involving the left coronary or multivessel. So early onset of ST depression in, sorry, can you guys hear me? Dr. Kofi said I can barely hear.
We
It's
can hear
Dr.
you.
Network, or we can hear you.
We can hear you.
Okay, thank you. So I was talking about pointers to multivessel disease on exercise test. So I said early onset of ST segment depression in the first stage of Bruce protocol. That's 1. 2, if there's ST depression greater or equal to 2 millimeter involving 5 or more leads, it's also an indicator. Or if during recovery period this ST depression persists for greater than 5 minutes, is also an indication. So for a less severe disease, within 5 minutes, the ST depression should reverse back. But if it doesn't, if it persists, it also shows that it's a severe disease or multivessel. Then also, if there's ST segment elevation in all the leads except AVR, if we see ST segment elevation in only AVR, it doesn't point to multivessel disease. But if we see it in other leads, yes, it points to multivessel disease. So once the patient start exercising and we start seeing ST elevation, it also shows that the disease is severe or is multivessel. Then also sustained ventricular tachycardia. Once the patient starts exercise and we see sustained ventricular tachycardia, it's also a pointer to severe disease. Then lastly, if the patient have sustained decrease in systolic blood pressure greater than 10 millimeter of mercury, or if the patient's systolic blood pressure fails to appreciate by 10 millimeter of mercury with exercise, is also a pointer. So now let's go back to the options. Early onset of ST depression is true. So that means it's not what we are looking for. Persistence of ST changes late into recovery phase is true. ST segment elevation in lead AVR is false. So this is the answer. Sustained ventricular tachycardia, yes, is a pointer. Failure to increase systolic blood pressure by at least 10 millimeter of mercury is true. Is also a pointer. So C is our answer here. Any contribution?
Comment and contribution, please. Please, next question, ma.
49. Which of the following statements regarding auscultatory findings in aortic stenosis is true? Aortic stenosis, let me just say a little about aortic stenosis. Aortic stenosis murmur is best heard in the second intercostal space, the right upper sternal border. That's the right upper sternal border, second intercostal space on the right. And it's a systolic ejection murmur. It's high pitched and is crescendo decrescendo murmur. So now I want to read the options. Option A, initial squatting decreases the intensity of the murmur. Initial squatting decreases the intensity of the murmur. Squatting increases preload, thereby increasing venous return to the left ventricle. So it's going to increase the intensity of AS murmur. So this makes it false. The murmur is increased in intensity during strain phase of Valsalva maneuver. This is also false. Valsalva maneuver does the opposite of what squatting does. Valsalva decreases preload, thereby decreasing left ventricular volume, thereby it will decrease the murmur in aortic stenosis. In patients with premature ventricular contractions, aortic stenosis can be differentiated from mitral regurgitation because there's beat-to-beat variation in the intensity of the AS murmur, while the intensity of MR remains constant. This is true. Once there's a PVC where the reading is irregular, so any point following the PVC, if we remember, there's like a compensatory pulse. So this pulse allows the ventricle to fill more, so it will pump out more blood at that point. So this will give a beat-to-beat variability. So once the blood is more in the left ventricle, there will be turbulence across the aortic valve. So it's going to give a louder murmur. Then when there is no PVC, there will now be the volume will not be that much because there's no that compensatory pulse. So the intensity won't be as loud as the one following a PVC. So this is the answer. So for MR, it remains constant. Then D, respiration typically has a prominent effect on the intensity of the murmur. This is false. Aortic stenosis murmur is a left-sided murmur. We know that respiration, that's mainly inspiration, has effects on right-sided murmurs. Any comments? Okay, 50.
Yeah.
A 59-year-old business executive presents because of episodes of retrosternal chest discomfort that does not radiate. It is an aching, burning sensation occurring most frequently at night, occasionally awakening the patient shortly after he has fallen asleep. It does not occur while walking or climbing stairs. His internist prescribed nitroglycerin, which he has taken infrequently. It does seem to relieve his discomfort, usually within 10 to 20 minutes. The previous day, during a luncheon meeting, he had a severe episode while presenting a new financial plan. The discomfort seemed to lessen when he sat down and he finished his lunch. The most likely explanation for his chest discomfort is A. Prince metal angina, B. Esophageal reflux and spasm, C. Pericarditis, D. Unstable angina pectoris, E. Biliary colic. Okay, from this question, this retrosternal chest pain, we want to first know whether it's coming from a cardiac source or not. So this chest pain is retrosternal, one, but it does not radiate. So it's not radiating to the neck or the jaw or the arm. Two, this pain is not worsened by exercise. It does not occur while walking or climbing staircase. That's another thing about this pain. Then also, though nitroglycerin works for it, but just for some few minutes. And then this pain wakes him up at night when he has fallen asleep. That means he's in supine position. So by looking at the characteristics of this pain, it doesn't seem to be coming from a cardiac source. Most times, pain from esophageal reflux and spasm, this is the character. The pain is relieved by food because they said when he started having the pain, then he now sat down and finished his lunch and the discomfort lessened. So once there's a spasm and they now eat, it tends to like temporarily dilate or relieve the spasm. So they tend to feel better. So that is why the answer is esophageal reflux and spasm. Esophageal reflux and spasm. Any comments?
Any contribution or comments, please? Okay, I think there is none.
Okay.
Thank you, Doctor. Hello. Okay, yes, Prof is back. Yes, Prof. Thank you. I'll just calling you.
Yeah, so quick one. For question 48, it's important to state that for question 48, I wanted to bring something to your attention. So that option C, ST elevation in the AVR is actually a classical or more specific for the diagnosis of a left main disease. So you see it in the ECKG, or patient has gone for a stress ECG, and you see elevation, ST elevation in AVR. That's a left main disease, actually. Next is that you can, for the option E, the blood pressure can actually fall. Okay. In them. So blood pressure can actually fall in patients with severe coronary artery disease. So I just want you to have that in mind. Okay, I wanted to ask for question 49. Can you differentiate between the maneuvers that worsen the murmur in open from that of aortic stenosis?
Okay.
What is the
Okay, maybe you were not around then. I explained it. Okay, I said that in aortic stenosis, okay, first of all, anything that increases venous return in AS will increase the intensity of the murmur, while in HOCM is going to decrease the intensity. Then anything that decreases venous return in AS is going to decrease the intensity of the murmur, while in HOCM is going to increase the intensity of the murmur. So for example, squatting increases preload, thereby it increases venous return and then increases left ventricular volume. So it's going to worsen or increase the intensity of AS murmur, while it's going to decrease the intensity of HOCM because there will now be more space between the hypertrophied septum and the anterior mitral valve leaflet. So it will decrease the murmur. But when there is anything that decreases preload, will narrow the space between the septum and the anterior mitral valve leaflet, thereby worsening the outflow obstruction and increasing the intensity of the murmur.
Okay, so the question will be, so I want you to get something clear. So why will, for example, increased venous return worsen AS momo? Why?
Okay, because there will be more blood flow in the left ventricle and there will be more turbulence across the valve. So the more the intensity will increase.
Okay, one. Any other reason? Any other reason? Hello, am I audible?
Yes, I can hear you. I can hear
Yes.
you.
Okay. Any other reason?
No, really. That's what I know. I just
Okay.
know that more blood, more turbulence across the valve. So there will be.
Okay. So so it's important to emphasize that the increase in the end diastolic volume is going to prolong. So the longer the duration of systole, the longer the duration of the murmur. Okay, so that means if there's increase in diastolic volume, you're likely to have a longer duration for the systole. So apart from the increased turbulence that will flow when there's systolic contraction, the duration of the systole also is also going to affect the duration of the murmur, especially when it's a severe AS. So that is another reason why the murmur will be more turbulent flow, and the duration affects the murmur on AS. So that is quite different from open. Now, so in buttressing question number 48, that option C, I posted something on the platform. So anywhere you see ST elevation in AVR with generalized ST depression, think of left main disease. I've posted something on the cardiology forum platform, an article. Please don't miss it. It's going to be classical for your clinical practice. The last thing I just wanted to summarize is the explanation of your QPQS. You have a fantastic explanation. Just for as a take-home message to our colleagues, is that try to. It's not hard to know. You just try to put value inside this thing. For example, when QP equals QS, you expect that QP talks about cardiac output from the right ventricle, QS cardiac output from the left ventricle. And in a normal patient that does not have a shunt, it should be equal. That means if you are producing 5 liters of cardiac output from the right ventricle, it should also be 5 liters from the left ventricle if there's no shunting. So in a scenario where there's shunting, that means one chamber will have larger volume than the other, right? So if, for instance, you have 6 liters from the right ventricle and 3 liters from the left ventricle, that means you have a QPQS of 2, right? So that means that there is already a shunting for the right ventricle to have 6 liters and left ventricle to have 3 liters. That means the blood is moving from somewhere to the other. So that means it's shunting from the left to the right. So if you have a QPQS of 2 or above 1, it means that blood has left the left ventricle to be filling the right ventricle through the shunt. You get? So that it will be a quick assessment for you in the exam so that you won't get confused. So a QPQS above 1 tells you that something has filled the right ventricle more than the left ventricle. So it's a ratio. What you're calculating is a ratio. So it makes it faster and easier for you to reason the exam. Okay? Okay, so that's all. Thank you very much.
Thank you so much, Prof. And we really, really appreciate you, sir. Sir, there was an outstanding question on LGA. That's question 45 that we were talking about earlier when the network was unstable, sir.
Okay. Oh, sorry.
Yeah.
Yes, the question was, yes. Can
Yeah.
you help me come into the image again? So I
Yes, sir.
want to, if I get the question clearly, the person was asking if this image was subendocardial, right?
Yes, I think
Endocardial, or if it's a transmural impact.
Or
it's
it
trans.
right. So I was trying to emphasize. Can you zoom more so that people can see it? Yes, so they can see the, so you can help us put the arrow now on the late ganglion enhancement. So that white patch. So that is the late gadolinium enhancement. So the physiology behind it is that when you give gadolinium, you expect a filling and a washout period. So after about 30 minutes, at least all the gadolinium should have washed out from the myocardium, because it's at the, when you give the gadolinium, it will fill the whole of the myocardium, apart from the apart from the chamber. The myocardium, the muscle itself will be filled, will become white. Everything will become white. Okay. Now, so you wait a duration. Usually, I know they use 30 minutes. That after 30 minutes, the whole contrast should be washed out from the chamber, from the wall of the myocardium. All right. So that means you should not see any gadolinium in the wall. Okay. So if you are seeing gadolinium in the wall after that 30 minutes, that means that it was not washed out. That's number one. Number two, that means that that place does not have good vascular supply. Because if it has a good vascular supply, then there should be a washout. It should wash out fully. So that simply means that if it does not have a good vascular supply, then that means that that place is now a fibrotic area. So that means there's fibrosis there. So that is why fibrosis will stay longer, will retain the contrast more than the normal myocardium, normal viable tissue. Okay. So in essence, the summary of what we're just saying is that when you see the white patch, which signifies late gadolinium enhancement, that simply means you are seeing a scar. It's fibrosis you are seeing. It is not a normal myocardium. Okay. Now, so for you to now reason out in exam, if you are seeing the white patch that is just less than 50% of the whole myocardium, so you can see that if you look at the thickness, and you can use your arrow to measure the thickness of the interventricular septum, the full thickness of the interventricular septum.
So is he here?
Yeah, so that's interventricular septum because it's separating the right and left ventricle now, right?
Yes,
so
sir.
you can see the full thickness of the interventricular septum up to the layer of the scar, the late ganglion enhancement. So we're just measuring the full thickness. Okay, good. So you can see that that scar is less than 50% of the whole myocardium, right? If you want I mean, 50% of the thickness of the interventricular septum. So that makes it subendocardial. Okay. Now, if it is full thickness, meaning that the whole of the thickness of the myocardium is white. Yes, good. So if the whole thickness is white, then that is transmural. That means that the whole of the myocardium of the interventricular septum is affected. So do you get the difference now between transmural and subendocardial?
Yes, sir.
Yes, sir.
Okay, so that's in essence, patient to benefit from revascularization.
Exactly. So the patient should benefit from revascularization because there is still viable tissue.
Yeah, viable tissue.
Exactly. There's still viable tissue that should be vascularized. Okay.
Wow. Prof, thank you so much. We are very, very grateful, sir. Thank you, sir. Please, do we have any comments or questions? We still have like 14 minutes to go. we will have loved to go on ahead to the next questions, but it seems as if everybody had a busy day. But I don't think it will be an excuse. So I don't know. So we might need to end here tonight, but going forward, please, I just want us to encourage ourselves. It's barely 8 weeks to this exam and we have less time. What we are looking at is a place where we can at least do 30 questions per day, and in a week at least do about roughly 120 to 150 questions, if not more. That's what we are looking at because there are still so many other things to cover. So I just want to encourage us all, even if it's not yet your time to present, don't let us assume that it won't be our turn. Let's just prepare ahead. And if it is possible to even go through all the questions or the ones before your own, so that the class will be a little bit more interactive, please, let's just try to do that. But I don't know that there are other people on the platform that have more suggestion, but we need to really move fast. We were thinking that we'll be able to do 30 questions tonight, but unfortunately we fall short of that. So please, averagely, we are aiming at 30 questions. 30 questions, that's what we are aiming at, 30 questions at least per day now, because we have less time. So please, let all of us, let's just try, let's push ourselves. Let's push ourselves. I hope I'm audible. I don't know, Chief Okopi, Chief Ugo, I don't know whether other people have comments. We navigate this. Hello, please, am I audible?
Yes, you.
Yes,
Okay.
you are very.
The whole platform was very quiet, so I was just wondering, am I audible? Please, let's just try. We can call on anybody at any time. Let's just try. Let's do this together, and so that we can finish and do other things too. Thank you so much, everyone, for coming tonight. Thank you so much, Prof. Chief Okopi, Chief Kweke, Prof. I don't know whether you have any comment for us. Thank you.
Yeah, just want us to actually gain speed. Speed is very important, as you said. There are still many things to do. There's the Viva section. There is the assessment, as in review of past questions. So there's a lot to do, please. Let's move to speed to support you guys. Thank you.
Yes, thank you so much, Prof. Guys, I think this time is quite short. We also know that Prof's book, at least you will see about 10 to 20 questions will come out from Prof's book. So let's add some speed. Like for tomorrow, let's try and please review all our sessions so that we can just rush through it. And then if you have your Oxford handbook, please also browse through it. And then Prof's book. If you don't have Prof's book, you can alert us to get it across to you. I believe from tomorrow, please, let's work up. And just the way Uzoku suggested, we might have to add Saturday and Sunday. But let's keep it in mind. But so far, this is the second day. We can do better tomorrow, but we're doing fine. Thank you.
Chief Kweke, sir.
Yeah, hello, sorry. So if you see my table right now, you will just pray for me. Doing 3 things at a time is not easy, but trying to catch up with everything at once. Yeah, I think we're moving fast. Let's keep on the pace, but we need to move faster. So we have about 700 questions and we have 2 months. How many weeks, how many days in 2 months? 30 days, 60 divided by 700. 60 divided by 700, let's say 600. So that's about 10, minimum of 10 questions every day. So if we go by minimum of 10 questions every day, take us about 2 months. And of course, we know that there are other things we need to cover. So covering 10 thereabouts, if you put the plan in perspective, it's so clear that we are already behind. So we need to think of another plan to be able to catch up. Okay, so that we can do more questions and move forward. I think we're covering like 20 per day, is it not?
Yes, sir.
So if we're doing 20, if we can still raise it to 30 in 3 hours, so that would be fantastic. 30 in 3 hours, that would be a good one. So I know that sometimes explanations and all that, they're important for better understanding. So we need to manage speed and understanding. So I have to manage them so that we don't lose understanding because we want to catch up with speed. In an attempt to understand, we don't stay in one topic and lose the other. So we have to balance both of them. So it's been a great one. So thank you so much for being on point and everyone that showed up tonight. Prof, once again, thank you for always being there to help. Thank you. Good night from me tonight.
Thank you so much, Chief Kweke. Thank you, everyone. And a big thank you to Prof for always being available for us. Tomorrow is another time. We hope that we will be faster and we'll be able to cover more ground. Thank you, everyone. Please, if you have suggestions, you can private chat me or private chat the Board of Management so that we can navigate this. We pray that it will be success at the end of the day for each and everyone. Thank you so much and good night, everyone.
Please, as you are going, I drop a YouTube link. Just click on that and subscribe. We're trying to build a YouTube video so that we can move from there. Thank you. Bye-bye.
Bye, sir. Noted, sir. Thank you.
Yeah.